As part of the health reform, we've got much tighter collaboration with the local hospital networks, or the local health districts as they're called in some other states. Other strategic partners like universities, which is really helping in terms of doing things like joint planning. There's been a lot of rhetoric around the health reform and what Medicare Locals are going to be able to do in terms of, fixing primary health care, and then they gave us $1.50 to do it with, so that's the scarcity that I've got in inverted commas there. Expectations, I think, are high. In the ACT in particular, we've got a very active healthcare consumer cohort. They're well informed, they want good health care, and general practice is feeling that, along with the hospitals, and I'm sure that's happening elsewhere as well. There are opportunities galore for nurses at the moment, challenges galore, they don't go away. I think primary health care really is the buzzword at the moment with the health reform that's going on, which is very exciting for someone who's sort of been around this space for about 10 or 11 years. I think the opportunities that we've got right now, we haven't had before. The practice nurse role, as you would know, it's pretty well documented, but it is evolving, and I think, and Paula agrees, and I'm sure you do all agree as well, that there's potential for us to harness what nurses are doing in a much better way, though there is some fantastic stuff going on already. So just a little bit about the ACT to give you the context, I suppose, for the support program that we want to offer practice nurses in response to what's happening in the ACT. We were one of the first tranche Medicare Locals out of 3, and if you're not that engaged with your Medicare Local, just be aware that there were 3 waves. So the Medicare Locals that were in the first tranche are probably a little bit further advanced past the transition stage, which was quite a challenging process for some. So just bear that in mind. Some programs are more mature, I suppose, than others. We've got about a population of about 370,000 people in Canberra. We're healthy, wealthy, well-educated, but they're getting, we are getting older and fatter. More chronic disease. This is a picture that's not unique. We've got about a 1.3% population of Aboriginal and Torres Strait Islander people, long-standing settlement site for refugees, and the thing that's unique about Canberra is our hidden pockets of disadvantage, and practice nurses know this stuff intuitively, working in a practice population. So how we actually support nurses to look after this population is what we're interested in. There's been a long-standing GP shortage, which seems to be easing in the ACT. There's around 400 GPs and about 170 practice nurses. Most are registered nurses, mostly part-time. And interestingly, one of the things that we grapple with in the ACT is that there's a lot of practice nurse turnover. Across Australia, the nurses in the ACT are the highest paid in the country, so it's not salary. We haven't sort of been able to put our finger on why that's happening, but that's something that we want to look at in the future and see why that's happening, to see if we can improve retention. We also have some nurse practitioners, just a very small group, but there's some fabulous work happening around absolute risk for cardiovascular disease in general practice settings. I'm not going to talk very much about that here, but you will be hearing about it at conferences in the future, I think, because the outcomes and the impact that the nurse practitioners are able to have in these sorts of programs is very, very impressive. It's always good to throw in a joke when you've... so you might wonder why I'm showing you that, but my thinking is that Medicare Locals now and divisions in the past didn't have this focus, but population health is something that we're becoming much more interested in and much more informed about, which is why I've tried to give you that snapshot of what happens in the ACT. Every year, all 61 Medicare Locals in the country are required to submit a needs assessment to our funder, Department of Health and Ageing. And it's around, trying to understand our populations better. In the past, we've been, funding short-term projects, some longer programs. They weren't necessarily linked at all with what the needs of the population were. That's just not what the funding allowed us to do. But under health reform, times are changing. There is now access to a small but hopefully growing bucket of flexible funds so that if we can identify population health needs, we can then address them, and practice nurses are part of the journey. That's really the bottom line. This guy clearly has a few issues getting his priorities right, but we hope with the work that we've done in our needs assessment that we'll do a better job of that. In terms of governance and membership and where practice nurses fit, in the ACT we do have a practice nurse sitting on our board of 10. She was elected by the membership at our first AGM, and she was so popular and did such a great job on the board that she was re-elected and reinstated for another 3 years. We've got nurses also sitting on a number of program and project steering committees and also board committees. And interestingly, in the last few months, the remuneration for nurses and allied health has been raised to the same level as GPs, which is $130 an hour for the time they give us sitting on committees, which I think is a real sign of how times are changing, because it used to be $50 for nurses, $130 for GPs. Now there's a recognition at board level that the contribution is equal, and so the remuneration should be as well. So that's been a win, I think. Membership models vary around the country. Ours is a hybrid, which means that individual nurses can join. That could be why there weren't a lot of hands that went up when I asked which of you were members. It might be that your practice is able to be a member and you're not. Our thinking was that in terms of engaging with nurses, offering individual membership was the way to go. We've just hit just over the 1,000 member mark in the ACT, which is administratively interesting, but a great way to engage. And about 170, as I said, all of the practice nurses are full members. In terms of member benefits, we do offer a lot of education and events. That's been a sort of a flagship program for ACT Division prior to us becoming a Medicare Local, and that's continued on. You would probably all find that your Medicare Locals are in some way offering support around events and education, so it's worthwhile getting in touch for that reason alone if you haven't already. The education and events that we run, we try to make sure that it's the latest in contemporary clinical coordinated care. We also offer multidisciplinary networking events to try to break down some of those barriers across the professions, which have been really popular. And it's around, allowing peers to come together around shared topics of interest, which always seems to work well. We've got an electronic newsletter that goes out. I'm sure there wouldn't be a Medicare Local in the country that's not doing that. And if they've got your email address and they can send you their electronic bulletins, it's a great way to stay in touch. Ours is called 252 because it comes out fortnightly. There's a health interaction newsletter that also comes out electronically now from our Medicare Local, which is around, more issues, policy, if you're interested in what's going on in health reform. 252 is more clinical, this is more at that higher level, so it's a good way to stay in touch with what's happening. There's also always the website. And membership, I think importantly, we're really keen to engage with our membership so that there's an opportunity, from practice nurses, any of the members, GPs, psychologists, allied health, have that option to influence policy that's being formed. And this is very new. I don't think that existed in divisions of general practice so much, but these are the sorts of opportunities that health reform is giving us. So Paula's going to talk a little bit more about the nitty-gritty of what we do in our practice support program, and then I'll come back at the end.
Hi, as Jenny said, I'm Paula Sharp. I'm the Practice Support Manager in ACT. Our practice support model is an evolving model as well, as with most things in the Medicare Local world. At the moment we have, in our team, we have practice support officers. We have 3 of those over that cover the ACT. That's divided into a geographic sort of mix so that some of the roles that they play can just be centred around an area, so they don't have too much time, too much space to cover. We also divide their roles. 2 of those are registered nurses, but we divide their roles among the things that they need to do. So we have one that concentrates on accreditation and the support for accreditation in the practice, another one that works around data quality and training people in clinical audit tools, and another that works with chronic disease and Medicare item numbers. they generally visit the practices and assist with anything that they need help with at the time. One of those is a very experienced practice support officer. Her name is Jill, and she describes herself as the human Google. So when you don't know something, you can ask Jill and she'll find it out. So I encourage you to use your practice support officers for that reason. If there's something that you want to know, it's likely that someone else has already asked that question. So we try and share that information among the practices and the practice nurses. We also have a nursing and general practice officer who concentrates on specific nursing issues and things that come forward for nursing, and she coordinates our events and meetings around nurses. We have an immunisation practice support officer as well, and she works with the National Immunisation Program and implementing things that help ACT stay at the top of the national immunisation rates. We have a diabetes project officer whose primary role at the moment is working in an ACT Medicare Local funded and initiated collaborative around diabetes and prevention and management with 6 practices in the ACT. We also have a practice support officer with a clinical governance role, and she coordinates meetings. At the moment we are addressing our clinical governance issues within our own Medicare Local programs first, and then we hope to have a greater impact in the practices. We also work closely with the e-health team, so we'll give the AMLA e-health team a plug there as well, so we assist them in the role that they play. So what we do is as I said, it's a varied role. We run a lot of education and events. We try and integrate those events around different topics. So at the moment we're promoting a multidisciplinary event around diabetes with Diabetes ACT, and then alongside that, a month later, we're going to run an education event for nurses around completion of the cycle of care and what skills you need to have to adequately attain that. Also, we work closely with the AMLA Nursing and General Practice program to run the events that they provide as well. We have recently worked with the College of Nursing, updating the immunisation program, immunisation course that they run for nurses. It hadn't been applicable to ACT nurses, and so we worked with them to update that. We also do lots of practice visits around data quality, assisting with clinical audit tool training, assisting with accreditation and things specific to nursing around how to train your staff around triage and infection control. We also support external programs, and one of our big focuses has been the CVC training. We've done training, the Flinders training for nurses in the ACT recently. We've developed resources for practice nurses to assist with planning and billing, and we do one-on-one visits and help identify target patients. We've also just commenced a new orientation program that we've developed in the ACT. We have, as Jenny said, we have problems retaining nurses, and so we've taken the current program we're using and remodelled it to fit the ACT. So we do follow-up visits in the practice. We have a short time where we see the nurses at the Medicare Local and give them some initial training, and then we give them 6 weeks of weekly support in their practice. And that seems we've already provided orientation for twice in the 2 sessions we've run this year for twice as many nurses as we did last year. So we feel that that's a successful program so far. So that's what we do. So where to next? We're going to develop and expand our orientation program. We're going to look at what that's, how that's going for nurses, and hopefully get some update our content. We're going to. I think you're just going to do this bit, Jennifer. Yeah. Okay. So we're going to explore new opportunities for nurses and expand our orientation, our education program.
And just finally, last slide, Lynn, so we will go over time. One of the things that we've noticed, observed, it's only anecdotal, but when the practice nurse incentive payment scheme came in, what we were hearing from local practice nurses, including our board member, was that their practice actually took a step backwards, and some of you in the room may have found that as well, whereas previously nurses were running nurse-led clinics around immunisation or wound management or whatever the case may be. when the new funding model came in, the angst around the business bottom line from the general practice, which is the private business, was such that the GPs were then going back in and claiming an item 3 or an item 23, which is clearly not what the impact. There's lots of heads nodding around the room, so I mean we know we're onto something here because we always get the same response. The idea that we've got with this collaboration with ANU is to drill down a little bit more about what is actually happening there. We don't think there has been a financial impact, but unfortunately the practice now has changed, regardless of the fact whether there was a financial impact or not, and it's going to be very difficult potentially to undo those new workflows that have emerged. So kind of not quite what was intended, but it's not the end of not the end of the world. What ultimately the thinking is with this partnership with ANU, and it's very early days, we might be back presenting this at next year's conference and giving you a tool that you can use if it all pans out. We don't even have an agreement signed, but I'm interested in whether I get nods to this or not actually. Because Medicare Locals are now much better defining what the population needs are across their jurisdictions and working with practices around individual practice population health needs, what we want to come up with is a tool so that we can map what the practice nurse's skills and qualifications are against what the practice population health needs are, and then develop our support program to match what the needs are. Does that make sense? So we're sort of, rather than upskilling nurses in cervical screening when all I do is chronic disease management, which is pretty much what we've done in the past, we want to have a much more evidence-based process behind the program that we're running. So that's the grand idea. As I said, hopefully it will come off. There are some nods, so that's good. You're all going, that's a really silly idea. We don't think there's a tool like that in existence at the moment, and we're really lucky to have ANU and some great people like Chris Phillips and Sally Hall on our doorstep that are willing to talk with us and help flesh this out. So watch this space. And I don't think we've got time for questions, do we? Or maybe? Okay, questions at the end. Thank you.